Good afternoon, everyone. Since Dr. Gaurav Luthra couldn't make it here, I'm just filling in his space and covering a little bit about epithelial thickness maps. Ever since the advent of a good spectral domain OCT, nowadays almost every OCT device also comes with an anterior segment module, and we can capture good epithelial maps, and this is becoming a very integral part of our cornea and refractive surgery practice. So essentially, these epithelial maps give us information at 6, 9 mm and some in certain devices even beyond that. But it is most importantly the central 6 mm that we are more concerned about than the peripheral epithelium, which while we may get data, doesn't really mean much. One important factor which we've always recognized with the epithelium is that it is a main component for compensatory epithelial hyperplasia, which leads on to myopic regression. So what we mean by that is the epithelium is trying to smoothen the cornea. So where there is a change in the curvature, that is in the mid-periphery, from a flat central cornea to a change in the curvature beyond the transition zone, where the epithelium heaps up to make it a smoother cornea. So as you can see here, in any degree of refractive correction, the amount of change in the center is the least, and the mid-periphery is the most. So the mid-peripheral change then leads on to an overall increase in epithelial thickness. This induces the regression. Again, I've just put up this example to highlight that it does not necessarily mean a thinner cornea has a thicker epithelium. It is actually just trying to smoothen the cornea. So a uniformly thin cornea or a uniformly thicker cornea may have a thin or thicker epithelium. The epithelial thickness map has also been used to detect early cases of keratoconus. And I'm just initially showing a more advanced keratoconic slide where essentially we have the typical donut pattern which has been described. There are of course other patterns also which are available, but again the epithelium is trying to smoothen the anterior contour. So at the apex it is thinnest, and at the base of the cone it is thicker, trying to smoothen the keratoconic eye and give a better anterior surface to the cornea. Whereas while in advanced keratoconus it really doesn't mean much and doesn't add much value, it is in these early cases where we are more concerned. Now, these are possibly patients who come for pre-refractive surgery screening, and you see a isolated IS asymmetry here. Now, is this a red flag sign? Possibly not, because you see that the epithelium is a little heaped up in the inferior in this patient. So possibly a little bit of dry eye, contact lens issues, and these need to be corrected and a repeat scan can be taken. Whereas if you see this example, you see a cornea which is, again, there is a little asymmetry as you can see here, but you see this typical donut pattern where you see a thinner epithelium surrounded by a thicker epithelium. This is a red flag sign, and you need to be worried about this patient before you take up this patient for refractive surgery. So even as a screening tool, the epithelial maps are quite useful and add information whenever there is a doubt in the pentacam slides. That's why there's a lot of shift towards looking at the Bowman layer imaging itself, the Bowman layer thickness, which is available in certain ultra high frequency ultrasound machines, as well as in spectral domain OCTs. The most important area where epithelial thickness plays a role, as we already discussed, is in epithelial hyperplasia post-LASIK. Now, the next question is, when you have a thick epithelium like this, 68, 70 microns, what is the procedure of choice? Because if you remove the epithelium over such an eye, what would be the power that you would compensate for removing this epithelium? Because this 20 micron increase in epithelium itself is going to induce a myopic error. What would be the kind of growth of the epithelium once the patient heals? What would be the refractive effect of this epithelium, and what would be your compensation when you're correcting the power? So these are challenging questions when you have a thicker epithelium. So in some of these cases, you might do well to not disturb the epithelium and just do a flap lift and do the correction on the bed rather than doing just on the epithelium. If you don't measure this epithelium and use a standard PTK 50 micron mode and ablate, if you're ablating 2 microns, you might adjust 2 diopters of power, you might just end up ablating only the epithelium, and you might actually have no refractive effect at all. So these are things that need to be kept in mind when you're looking at this. This is just one. I'll close with this patient where was a fairly high refractive error, and you can see that it's mostly a spherical error, just a 0.5 cylinder, very normal topography. Patient after correction after 2 months, came with this refractive error of 1.5 diopter cylinder at this axis, which was not even there in the preoperative period. The topography again was very, very smooth, very normal. But when we looked at the epithelial thickness map, you can see that there is a asymmetric increase in the epithelial hyperplasia. This could have been caused either due to initial, during the healing, possible epithelial defect on table, which lead to a localized heaping of the epithelium in that area, or even a previous contact lens wearer who might be having some residual dry eye, which led to this epithelium. So before we go ahead and retreat, looking at this epithelium is very, very important. And in this patient, I did nothing but just to debride the epithelium and to wait and to see what the result is. 4 months after epithelial debridement, this patient actually had 6/6 vision, and the epithelium again became a normal profile, being a little thicker in the center and thinner in the mid-periphery. So this is a very important take-home message, that before you go ahead and retreat the cornea, look at the epithelium, whether it is thicker, thinner, whether there are any other red flag signs, and then go ahead with the treatment. So there's just a brief about the epithelial thickness. My main topic was to present certain case discussions, which I can present depending on the time available, and I can stop whenever.
No, go ahead.
So these are just a few interesting cases, different situations which we may come across in our day-to-day practice, and some take-home points from each of these cases. So this is a particular patient with a fairly high astigmatism. You can see +3 with a -7 and a +1 with a -5.5 in the other eye. The topography again is very, very regular. It's an absolutely normal cornea. Now you could do a laser correction also on these patients, but then because of the fairly high power, you would end up getting a regression, and also at such high levels of astigmatism, our correction with the laser treatment is also less accurate. So because the patient had a good anterior chamber depth, we decided to do a phakic IOL and implanted a toric IPCL in this patient. And this was uneventful surgery, very easy surgery. But on day 1, as you can see here, the pupil was peaking and the lens was tending to capture through the iris, through the pupillary margin. And this was there in both the eyes. And on ASOCT pictures also, you can see that the lens is tilting up. I took up this patient, applied pilocarpine on table, made the lens go down, came back only to see that a few days later, again the lens was coming up. It was tending to tilt. And because of the tilt induced by the optic capture, the patient was also having a very odd refractive error, which was not corresponding to the position of the lens or the shift or the axis of the lens which was implanted. So this is essentially a phakic IOL in a normal patient, just a high astigmatism, who can have optic capture. Now, this is possible with keratoconic eyes more commonly, because again in keratoconus you have a falsely high anterior chamber depth and therefore it can capture. But this patient did not have a falsely high anterior chamber depth. The peripheral anterior chamber was still normal. If for this particular vault I wouldn't have had to do any other case if not for the fact that the lens was tending to capture through the pupil. So it's good to exchange these lenses with a smaller size. But the main question here is, what do we do to avoid such a thing from happening? So the main idea is, whenever you are encountered with a high cylindrical error, please recheck all your measurements. Aim for, because of the natural curvature of the way the phakic IOL lenses are, they do have the mid-peripheral rise, and aiming for a lower vault is better. They will still not touch the crystalline lens, but will provide you with stability. So aim for at least 0.25 or 0.5 size lesser if you are faced with a patient with a high astigmatism, even in a non-keratoconic eye. This is just one of the points that I wanted to emphasize. Any views from panel?
I do agree. I mean, although the explanation for the fake keratoconus eye is because of the irregular AC depth, that you would go for a smaller thing. But herein again, In a
It's a
high
regular
astigma-
cornea.
regular cornea, I mean,
I just chose this example to highlight that it can happen with a
Can
central
happen.
steep cornea, even if it is a regular cornea and not just a keratoconic cornea.
Yeah.
So, with steeper corneas, there is a chance that our anterior chamber depth may be overestimated, or even if our anterior chamber depth measurement is accurate, the sizing of our lens may not be appropriate to the lens rise and the iris plane that is there for that particular patient.
yeah, 10.
As soon as I reduced it by 0.5 sizing, it was fine, sir.
Yes.
No, the sizing is done in the same way, madam. But we choose a lens which is
0.5 less.
0.5, or at least 0.25, if not 0.5, lesser than what you would have normally chosen for that same white to white. So, for example, if it is a if it is 11.5, I mean 12.5 white to white, 11.5 white to white, you would have normally chosen a 12.5 lens. But here you could choose a 12 or a 12.2 lens, a 12.25 lens if you're using Indian phakic IOLs. With ICL, maybe going for a 12.1. So the difference, instead of being a 1 millimeter, you're choosing a 0.6 millimeter. You're essentially undersizing this lens to prevent this excessive vaulting. Again, fortunately, yes. No, definitely not, madam. This is a very odd case where it's a very high cylinder without having any other ectasia or other issues. This which can happen, but generally low cylinders, no such correction is required. The idea is we are talking about a steeper cornea, steeper central cornea. ACD was 3.24, sir. Again, nothing abnormal. If you just look at the ACD itself, 3.2 is something which can be there even in a normal patient. But this was possibly recorded higher because the cornea was steeper in the center.
Yeah.
So, with more advancements in different machines coming up, lenticule extraction is becoming more common. And so, I've just put this occasional complication which can happen with any procedure, SMILE or LASIK, but this was pertaining to a procedure done after SMILE, where you can see that the patient had an uneventful SMILE procedure. 2 weeks post-operatively came with a blurring of vision with a 0.75 diopter improving to 20/20. When we looked at the interface, this patient had this localized epithelial nesting. Now, in a LASIK flap, normally we would lift and scrape it off, and that's quite easy. Whereas in SMILE, we are not able to lift. So the options which have been recommended are either using the Circle software, creating the cap into a flap and then removing the epithelium, or you just go ahead and try and scrape and remove the epithelium. You can again see here that this epithelial growth on ASOCT. So this is just the surgical video. Sorry. Yeah. So as you can see here, it's very well localized, and you can open up the same incision, just dissect out that plane and scrape the epithelium which has grown in, and usually this comes out like a sheet. Now, the reason I'm emphasizing this or showing this particular case is in most of these cases of SMILE or even in primary LASIK, especially in femtosecond LASIK, the epithelial ingrowth, if it is coming after a primary procedure, is essentially because of implantation from the tip of our instrument. When we are going ahead with the dissection, and these have limited proliferative capacity and do not go on growing. So once it has stabilized, you can go ahead and just wash it or peel it off, especially if it is affecting the vision or it is close to the visual axis. If it is not close to the visual axis, we can just safely observe them. They do not go on increasing. The rate of recurrence also is very low after these procedures, because again, we can take adequate care to do a sufficient interface wash in these cases. Normally, we don't do an interface wash post-SMILE. I think Dr. Sri Ganesh also highlighted it in his talk. We don't do an interface wash post-SMILE, but in case of such epithelial ingrowth, you can wash even with a little bit of dilute alcohol in the interface and then wash it off thoroughly, so that any residual epithelial cells are also destroyed and do not proliferate. I'll close with this case, and this is again a common situation that we come across previous contact lens wearers who've had an episode of infection, a CLPU or marginal keratitis, and there is a scar which is not right in the visual axis but in the paracentral area, which is going to involve your flap margin or your cap cut if you're doing a smile or a flap based procedure. So I think the common query is whether you would just stick to PRK in these eyes. The argument against PRK is if you are ablating on the scar, the ablation rate can be different and the refractive result might be little inconsistent when we are ablating through the scar. Whether you would just, if the patient has good acceptable quality of vision, whether you just go ahead with a phakic IOL or would you do a LASIK or a smile. I'm just showing a patient where I did a femtosecond LASIK. Now this is again not a one size fits all. This is just to incite a discussion where essentially you can see the scar in this particular region. It is post CLPU. Now, main concern when we are doing a femto LASIK is that there can be a vertical gas breakthrough. So, I've chosen a deeper flap, and as you can see, there is a vertical gas seeping through the scar, but it does not breach the epithelium. If we have a superficial flap, this would have definitely breached the epithelium and you'll have a localized buttonhole. But in this case, essentially, you will probably have inadequate laser pass in that area, but it would not breach the surface. So here you will have a flap which is now formed all in its entirety, but in this area you would not have a femtolaser dissection which happens. So it's important to treat this with care and go ahead and dissect all around this particular scar and then go ahead and lift underneath. The reason is so that during your manipulation you don't cause a localized flap tear. So once this is done, you will find that there is a little bit of force required as there is no femto dissection, but a posterior force because you are applying it along the posterior stroma and you don't point it anteriorly, and then you can dissect and lift and treat the scar. Sometimes you may have some residual elevation from the a deeper level of the scar, and you can remove it, debride it, and then go ahead with the ablation itself, and then go ahead and reposit the flap. As you can see, there is no buttonhole in this flap and it forms quite well. So even if you're doing a smile procedure, again, smile you can have, it might be a little more difficult because the localized lenticule dissection can be a little challenging, but it's important that we take a deeper cap cut or a deeper flap cut in these cases, and these patients can do quite well even in the presence of a localized scar.
Why would you not do a PRK instead?
Now, PRK can also be definitely done. In this particular case, the patient was wanting to leave abroad, didn't want a long recovery, and this was done. A PRK, if the scar is not going to be in your optic zone, is fine. But if there is a scar in the optic zone, maybe not in the center, but in the mid periphery, we have to be conscious, or we have to at least educate the patient that our refractive outcome may not be perfect, as our ablation rate or the residual effect of the scar itself may induce a small amount of irregular astigmatism in the final outcome of the procedure.
Thank you. Any discussion, any doubts you all have? Yes.
No, in this particular patient, I applied a BCL because again, overlaying that area where the vertical gas breakthrough happens, even if it has not breached the epithelium, it is still a very thin area. So applying a BCL whenever we have a localized thinning in our flap is a good idea, as it allows it to settle down and it heals well. You could even get away without applying a BCL. It's not a mandatory requirement, but whenever there is any epithelial defect or a thinner area, applying a BCL, especially when there is an epithelial defect, is important to avoid DLK or reduce the incidence of DLK. With a microkeratome also, I would recommend a deeper cut, but then a microkeratome is possibly, this is one area with a scar or post RK, or that would be an area where microkeratome stands over a femtosecond LASIK, because you don't have this problem of the laser not penetrating or a vertical gas breakthrough. This would be an area where you can use your microkeratome and create a good flap.
Thank you.